Hello, everybody. This is Allie Orwig with the Indiana Rural Health Association. We appreciate you joining us today. We've got an excellent presentation for all of you, but a couple quick housekeeping items before we get to that. The first is that we are recording today's session, so if you're not able to join us for the entire time, or if you'd like to share it after the fact, we will have this up on our YouTube channel by the end of the month. If you've not checked that out, we have a lot of great flex-funded lunch and learns up there from really over the years, a lot of great stuff. So if you haven't checked it out, please feel free to pop over to our YouTube channel anytime. The next thing is that we will be able to monitor the chat and the Q&A during today's session. So if you have any questions you'd like to ask, please feel free to drop that in the chat or the Q&A. You get that by hovering either at the top or bottom of the screen with your mouse, depending on which view mode you're in, and we'll be able to keep an eye on that. Alternately, you can hold your question for the end and use the raise hand function, and we can unmute your line. You'll be able to ask your question verbally that way. But without further ado, I am excited to have with us today Sandi Wagner. She has, for the last 10 years, implemented and operationalized enterprise virtual care programs for St. Francis Health in Oklahoma, Lutheran in Fort Wayne, Indiana, and Christus Health in Texas. For the last year and a half, she's been working with St. Francis Health leadership to make virtual care its own service line, like cardiology, oncology, and critical care. And she has launched an enterprise virtual nursing and virtual sitting program that is saving the health system just shy of $1 million, about 900,000 for every 60 med-surg beds they have. So she's going to share her launch strategy, what's worked well, some plans to scale the program, and more for inpatient service lines. So, Sandi?
Thank you very much. I appreciate the opportunity. One of the things that I love to do is, as you will find out, I'm very transparent. I will share the lessons learned and the things I've done to follow my face as well, because I hope that I can help others in any way, not make some of the same mistakes we did, or just any information that you find today to be helpful. So, as you can see in the slides, this is I had some other contributors that helped me with developing these slides, so I always give them credit on the front. Our chief nursing officer for the system and the clinical manager over the virtual nurses have helped with some of this information as well. Okay, I gotta get it to advance. There we go. Okay, so what we're gonna do today is just, the goals of today is to help with identifying ROI and key metrics and just where do you start? How do you define how to start? How do you determine technology? How did we determine technology? Developing workflows and implementation, and then current and future state, along with wins and lessons learned. So technology selection. So I was hired a little over 3 years ago. It was a new position that St. Francis decided they wanted to have a director over everything virtual services. And one of the first things out of the gate was they said, we need you to work towards bringing in virtual nursing, and we need you to help us determine a technology of choice for our system. It was coming out of COVID in the middle of, in the spring of 22. And like a lot of places, there was so much that happened during that pandemic that they had a hodgepodge of this over here is using DoxyMe, this one's over here is using Zoom. We hand grown some carts, and they had just not gotten to the point of selecting a technology of choice. So not only were we looking for a platform that we wanted to put all of our service lines on, was also tasked with that platform needs to have virtual sitting capabilities with the potential for, virtual nursing capabilities with the potential for virtual sitting to follow at a later point. And so we went on the hunt, and we vetted different technologies and, came to that conclusion of what we could use, what would work for us. And we had some specifics. The carts we had homegrown that they were using telepsych-wise, there was ligature risk with those. We didn't have pan-tilt Zoom capabilities. And then we didn't have the staff or the process to do all that fleet monitoring of the devices to support things like our stroke and other things like that. So we really needed to step up the game a little bit, technology across the board, and not just for virtual nursing. So this was our plan to standardize everything. Other things was it needed to integrate into Epic. We didn't want people to having to go in and out of programs. The solution needed to support inpatient virtual programs as well as outpatient. We wanted an end-to-end solution, whether we decided to use everything or not of it. We wanted a solution that as we grow, we knew it could grow with us. And then what was best practice in technology for acute care settings. And that kind of goes back to that, live fleet monitoring for the acute, the pan tilt zoom and all of those things when you start getting into real acute stuff, peripheral availability. We looked at all of that. Regardless of the state we were in, we wanted to know we could grow with it. So they gave me my wishes on who we wanted to bring to this team to vet and select. And so as you could see, we had, quite a bit of executive leadership involved in looking at this and looking at the technology and asking all their questions and contemplating what they knew they needed to switch current things to and how that would function in addition to growth opportunities that they had on their horizon. So why did we select the technology we did? Well, it had the end-to-end solutions. It gave us a product to standardize across the system. It did allow us to standardize things if someone's from their home, if they're in their office, they're in an acute bed. There's ability to integrate multiple things. And as key, it had the virtual nursing support. Not only did it have the virtual nursing platform, there was a huge at the table helping us plan our workflows and gleaning from everywhere they'd been in other places and working through those workflows with us and at the table. I think Teladoc probably got a little overwhelmed, maybe, I don't know, but we put them to the table of every one of our planning meetings just so they could be there for all the support and help us through. So hopefully we didn't make mistakes. Epic integration, obviously, call light integration. We haven't utilized that, but we knew we wanted that on the horizon. And we could put individual cameras in the rooms, real-time with the knocking and real-time integration. We didn't want FTEs to be pushing carts around because when we're spreading virtual nursing in all these rooms, that would be, defeating some of the purpose. And then again, the pan tilt zoom, as we had talked about before. I love this picture. This was our very first virtual nurse hired. Her name is Joy, and she is just amazing at her ownership and leadership in just coming on board and helping them all define their role and grow once it got thrown to them. So this was our pro forma that we started with. As you do, you have to go to Capitol and ask for money. And we needed hard dollars. We did not need any soft dollars to show with this. So we decided we were going to do a 6-month pilot on 81 beds. Our goal was to roll out virtual nursing across all of the med-surg beds across our system. And which is going to be 700-ish. But we were going to start with 81, which was 3 units. And we went back to the table like you should of what problem are we trying to solve? We're not just bringing in virtual nursing just because we want to ooh and ah, we want to be, cutting edge. That is part of our goal, but what problem will this solve for us? And so between that and finding those hard dollars, where we landed was we had a high concentration of RNs on several of our med-surg units in the mid to upper 90s%. And we decided that we wanted to utilize this opportunity to save some dollars and help the RNs practice at their full top of their practice by reducing that split to a 70-30 ratio on the RN LVN on these med-surg floors. So that would be a cost benefit. It would also help us in getting them used more in their potential and in their actual licensure roles. The other was reduction in turnover rate. Our goal was that with this, the turnover rates would decrease as well. And what I didn't show on here, as well as we were reducing travelers contracts and whatnot. So this was our pro forma to show what we were anticipating and what we expected to happen and that we took to capital. But we had another slide we took to capital as well. We said, okay, this is what we're going to do, and we're going to prove this, and we're going to knock your socks off. And then when we're done with that, we're coming back after that 6 months, and we're going to ask to roll across all the med-surg beds over a 2-year time period. So first year be X amount, the next year be X amount, because we wanted them to see what we really planned to do before it was all said and done, what we were going to come back and ask for. So these are our key metrics, indicators that we're following, along with the ones that we used for our ROI. And as you can see, our baseline and our targets. So our baseline, our RN turnover rate, 16.8. We wanted to get to a target of 15 on these units, increasing the LPNs. We're paying attention to reduce length of stay, but that wasn't one of our goals. As you know, so many initiatives and so many departments are focusing on that. We can't really claim it, but we did want to at least be able to watch it. We wanted to reduce our discharge order to discharge time. We from our average to 45 minutes. We wanted to reduce falls. And then we also threw in some press gaining questions because we wanted to pay attention to the nurse satisfaction and employee satisfaction, patient satisfaction on those floors. So these were our KPIs that included what was on the capital ROI, but also what we were wanting to monitor for ourselves. I will say one of the lessons that we learned in reducing the time from orders to discharge, we also had a goal to reduce the time from patient arrival to the floor to the admission completed, admission started to admission completed. There are wins in that, and we're seeing more efficiency, but don't be surprised if initially those lengthen. And it's not necessarily a bad thing. What we discovered was those RNs have time. Ours are task-based. So they have nothing in front of them to do but complete that admission or complete the discharge that they're doing at the time. Nothing else. They don't have any other patients under their care. That's the only thing they're doing. And you know what? They have more time to talk. They have more time to dig into the histories. They have more time to dig into asking those medication histories, which really helps with our med recs as things move on. They have more time to bring in all those extra little pieces of the conversation in the education and all of that. When you compare that to a bedside RN, she has however many other patients, and people are constantly buzzing her phone or hitting the call light into the room saying, hey, room so and so this, and can't focus. That patient she tries, or they try, but they can't focus specifically on that patient solely. They've got all these other things running around because they're responsible for other patients at the time. So our needle didn't move as quickly on reducing those average times because they were learning their roles and getting in those roles and learning how to dig deeper. And that's okay. We determined that was okay. Discharge is still a little bit of a priority that we're pushing a little harder on. But the bigger thing we're watching now is from the time the patient got to the floor to the time the nurse started the admission assessment, not completed it. We're still monitoring complete, but we wanted, it was a little more keen to pay attention that they were actually getting to them timely. So this was what we looked at in the beginning, and we were thinking about doing some team nursing, and we did start off with that. It didn't work well for us, but I know there are other systems that it did. And so we were looking at what task can only be done by a bedside RN. What tasks can the virtual nurses just totally take off of the bedside RN? And then what tasks are in the middle that they could share, or who could do either? And so this was what we came up with, which was really helpful on us preparing all of our workflows and what we needed to do. And so this changes over time. As I said, the team nursing didn't really work for us. What we found with us was we had these 81 patients and we had our virtual nurses and we were assigning them to units or, you in this unit, you have this one. What was happening is one floor, the doctor was on that floor and all those discharges were hitting, and this one didn't for a couple of hours. And so we would have one nurse just overloaded, really busy, and we'd have another nurse just had some things here and there. And it wasn't making sense for us. It made better sense for us to just pull them out to task based of when there's an admit, first nurse does it. There's a discharge, first nurse does it as they pop up on the list. They do prioritize the discharges over the admits if there's multiple hitting at a time. So this is one of our virtual nursing workflows. And this is based off of the patient was being admitted from the emergency department. And so as you can see, we worked through all these swim lanes and we were like, this is what this person will do. This is what the patient assignment center will do. This is what the bedside nurse will do. This is what the nurse tech will do. This is what the virtual nurse will do, and how they correlate and flow off of each other. What we landed on to make our cue that the patient's ready for the virtual nurse to do the admission status is the vital signs that were entered into the EMR once they got on the floor. That's the cue that the patient's on the floor. Then that populates it over to their task list automatically, and they see that it's ready. We couldn't make it off the admission order because we can't get out of a world of holds and bedside hallway beds and all of this. So that was where we landed with the best way for them to know that patient is on the floor and ready. Because the other pieces to that as well, for the patient to be ready, they have to know, what is this camera, what's it doing, what's going to happen, what is a virtual nurse. And so the people on the floor that receive the patient and are taking those vital signs and entering them in are having that conversation. We do virtual nursing here, and this is what's going to happen. And so it would be no surprise at that point in time. So implementation, I love these pictures as well. So you can see here to the left of this top picture is our Chief Nursing Officer, Sandi Leathers, and she is just amazing to work with. The one in the forefront is Tamara, who's the direct manager over our virtual nurses. And then this was our first group of virtual nurses that you see here. And then this is one of their cubicles that they sit in with, and you can see her there just having a good time doing her assessment or whatever she's doing. I don't know if she was posing or not, but that's a good picture. So to implement this, we installed the equipment. We did mock sessions. We, between the bedside staff and between our virtual nurses, just to let them kind of get used to it we even tested on some patients that were willing to, hey, can we play with this equipment in your room and let you see what this is? We did empty rooms. We just kind of felt out the whole thing on that and got everybody comfortable and ready. We staggered across the 3 units. We went live on 1 unit each week for 3 weeks to do the 81 beds. I would say I would not make that mistake again. I would have done all 3 at once and just ripped that Band-Aid off. And we can go into that in a little bit. So we were going to do, as you see the coverage, we started off just 7A to 7P. We had a small group of nurses. This was a pilot. We didn't know how well this was going to go. The heaviest admits discharge are during 7A to 7P. So we started with just that so that we could have 7 days a week to start with, and then work towards the night coverage as we went along and moved out of our pilot into approval to expand. So admits, discharges, patient education, the purposeful rounding, we pulled back when we removed them from being in those assignments. Now, there's a lot of collaboration that goes on between the bedside nurses and our virtual nurses, and it's not uncommon for them to say, hey, I'm going to be so busy over here. Can you peek in on this patient and ask them this question or double check whatever? I don't do it a whole lot, but if it's one that they've been freshly working with on admitting, they might, and they're always happy to reciprocate that. So future state, which I'm happy to say we are now at, is 24/7. We're not across all of our med-surg beds and ICUs, but we are in 314 beds at this time. Um, the other thing that we have implemented is our night RNs will do those chart audits for those floors. That gave us consistency on the chart audits that were completed. They were completed in the same manner and the same way across all of these. You know, an interesting thing, you have some units that they go through a chart audit and they're always 100%, no matter what on that unit. But that unit style is if they find it, they fix it then and they don't count it. And this other unit style over here is if they find it, even if they could fix it right then, it's a finding. So this gave some standard and consistency to that across the board. The physician and nurse rounding, we pulled that back as well and did not stick with that because we went away from that team model. Okay, so wins and lessons learned. So we were very purposeful in the units that we selected. And the one of the units we selected was a very tight, very high performing unit with a very strong leader, and that we weren't sure they would feel comfortable with us coming into their territory. Another one is just kind of average on what we thought, and another one we thought would be real receptive. We also picked units that one of them always had great satisfaction scores. Um, we did that purposely. And we found, because we wanted to see, you introduce something like this, and it's quite a disruptor, and your satisfaction scores are going to drop down a little bit. How long is it taking to recover? How quickly do we climb back up? Wanted to see that. So we did purposely formed a leadership team that developed all of the processes, workflows, policies, protocols, playbook for our virtual nurses. Our virtual nurses have a workflow like the diagram you saw earlier for every single, if it transfers from a floor, it's a transfer. If it comes from the ER, if it comes from OR, you know, whatever those are, they've got their workflows that they follow, and that's their playbook. They don't have to ask permission. That's their playbook. And the way we were able to stand behind that is we brought every nurse leader to the table across all of our med-surg units for the system that we plan to go to. And they were part of that team of planning and developing all of those workflows together. So they knew then what was coming as it got there, and they already understood, and they understood the standardization and the consistency. I will say I would not have, as I said, gone 1 week at a time on something so brand new like this, because we did run into the first unit that we go live with. They're pushing back and say, well, we don't want to do this. We want you to do this. We don't want, and so really hard adjustment. The first half of that week, they're stressing hard, butting heads with the virtual nurses, really territorial, really concerned, really fearful, and all the negative sides that come with it. There's a lot of positives, but all the negative adjustments. And our virtual nurses, this being brand new to them, they weren't solid in themselves yet either. And so then the end of the week, it'd start to even out. Well, what we did was we hit them with that 3 weeks in a row. The shock, the terror, the fear, all the negative sides of it, the first half of the week, they were dealing with that with the units until they all can get settled and then settle down, and then we're knocking the breath out of them again the next week. So would have just done all three at once, hindsight, because of that. So it's a disruptor for everybody. We thought we were very good about timing things, but we did not realize that the same morning and time of day that we were going live with this, the alcohol misuse screenings were going live in Epic the same time, and it caused all kinds of stressors for the navigation board and everything along with that. We did not have technical issues on go live. We had done enough solid testing and everything. We were very grateful. That was a win. I expected there to be something, but that was a win. We were pretty good with that. The virtual nurses we noticed were catching things that the other nurses didn't catch on time. Like the virtual nurse caught a new medication ordered that should not have been on discharge, and some other things that, again, our bedside nurses are amazing, but they're pulled in 50 million directions, and some they can't always just focus that, and that provides some opportunity for some of these things. Um, the virtual nurses can find things like, hey, the patient's in there, but their call light's not within reach. Or they found their bed sitting in the high position and can notify the nurse to lower it. So those were some wins, just some things that, when they pop in the room, it's an extra set of eyes on some things. And then another thing that we learned, besides not staggering those three, was getting those workflows out to the boots on the ground sooner. We really kind of got those workflows out to the boots on the ground like the week before, and didn't really give those bedside nurses times to really review those enough and ask enough of their questions, which I think fueled some of that, the shock and stress and trauma that happened in the first part of each week. So current state now, we're in 311, 314, I can't remember, 300 and something beds at this point in time, and still working to expand to the total. We have since also added the virtual sitting piece, which the ROI on that really is simple. We have inpatient sitters now, and well, when one inpatient sitter is now watching at least two patients, we've got an ROI. They watch more than that at a time. But that was the next piece. We rolled that out in December, this past December. And what we did was all the beds we had live at that time, they now had this. If the patient had a bedside sitter ordered, unless it was, SIHI or something along that line, and they're in one of these beds, then we give them the virtual sitter. And so from this point on, every floor that we add the virtual nursing to, they get the sitter option as well. I will say that it's very exciting to know that we don't have that shock and awe anymore as we come to a different unit. Now, what we have is we have them say, when are you coming to mine? I can't wait. This is so exciting. And so we're no longer experiencing, and we have not for quite a while, those stressors at the beginning. It's just the change adjustment that we go through, but they're so excited because they see how well it has helped assist these other units. We removed travelers from two of those units in the first 3 months, 100%, and really dropped it crazily. Our turnover rates we had one of those units had a really high turnover rate, and they dropped down to like 10 in the first 2 to 3 months. And so in our 6-month pilot, we had a 900,000 revenue positive above the expense of implementing this program. So I'm sure there's some things that I missed. If anybody has any crazy questions, I'm also happy for them to share my contact information with any of you if you have any questions. And that's just a insight into our journey at St. Francis and where we're at and what it's been doing for us.
Thank you, Sandy. I don't have any questions that have come in yet, but do you want to share your contact information, your email for people to reach out?
Absolutely. So, yes, my email, I can stop sharing my screen. Oh, there it is. Never mind. It is on the next slide.
Perfect. We will go ahead and leave it open for just a second to see if anybody has any questions they want to submit. But we so appreciate your time today. Very interesting and innovative. I know we've been hearing more and more about the virtual sitting and the virtual nursing and for some of our rural areas. I know nursing can be a real bugbear when it comes to workforce in our rural areas. So
Yes.
an interesting approach that we're seeing more and more of. But
Yes, very
let's see.
much.
Let's see. We do have a Q&A that has come in now. What is your future sitter to patient goal?
Oh, perfect. So at this point in time, we are limiting them at 12. Um, I think we may land somewhere around the 14, 15-ish when it's all said and done. But we wanted them to have time to adjust as well. And with us only being in so many rooms, many times they're only doing 4 or 6 apiece. And we're doing that purposefully so they can get that exposure because again, if they're watching only 3 patients, they're still saving us that many dollars, and it's giving them inching them in and letting them get super comfortable. We have quite a pool of in-person sitters, as you could imagine, across our system. Yeah, our main facility is a 1,200 bed facility, and so they sit not just on the med surg units, in all the areas. And so we're letting them really get their feet wet into it, and many times they will split off when they just have 4 and go ahead and bring in a second sitter to start, have 4 apiece, but their limit at this time, we're gonna limit them to 12.
Are there factors that'll allow you the confidence to increase the sitter to patient ratio?
Yeah, we pay attention to what the national averages are, what any regulatory things that may go along with it. Right now, we just don't have the demand that demands that it be that more at the moment because we're in so many limited beds per building, right? And there are in-person sitters that we're training to do this and they rotate in-person and whatnot. And so we've not reached a point yet where we had dialed them back to 12 and we needed them all to have more than 12 or any of them to have more than 12.
Okay. Well, not seeing any more questions come in, we'll go ahead and launch the poll. We do collect this data to be able to continue having these free, again, flex funded lunch and learns for everybody. So if you can go ahead and answer this one question for us, we'll keep the line open for just a minute longer here. But just appreciate everybody's time today. Sandi, appreciate you coming on and talking about potential intervention for us. Like I say, we're seeing it more and more in some of the rural areas. So I
Mhm.
think it's probably on the uptake.
Yeah, lots of application to it.
Indeed. Indeed. All right. Well, thank you, everybody. We'll go ahead and in today's session, again, this will be posted by the end of the month on our YouTube channel. We encourage you to check it out there and some of our other great content. Thank you all.
Thank you.